comes, the role of pathologist is very much important. That is main, very basic thing. Because recently I got a case from Adra. She had axillary nodes, both axillary nodes, I think, cervical also. And she was on ATT for 8 months. She was given ATT empirically because she had effusion and left axillary node in the lymphadenopathy. She was given ATT and then referred to me for further management. But before I stopped this ATT and subjected the patient for histopathology. It came out the metastatic cancer. So anything, any lymph node,
Lymphoma.
metastatic disease. So any lymph node or effusion, you should not give antitubercular therapy without any positive diagnosis of AFB or tuberculosis. That is the main, because so many cases they are getting antitubercular therapy without characterizing the patient. So pathologist role is very important in case of any lymph node enlargement. First, do all the investigation. First, do FNSC. If it is inconclusive, go for histopathology. Then other immunohistochemistry, etc. So this basic thing, don't start antitubercular therapy without giving proper histopathology.
Similarly, just I will extend you when you are seeing a case of lymphadenopathy, examine it, and it is a very typical. If it is a rubbery lymphadenopathy going in favor of something lymphoma, Hodgkin's cancer, but it is a matted and it is the puckered surrounding, then always tuberculosis should be ruled out. So clinical examination and followed by FNSC. Always just 3 days before, sir, one of your patient came to me for evaluation, and that girl is having one big. I was surprised to see she was having one big round here, and it was found to have seen the FNSC, it was already Hodgkin's. More than most of the patients they are keeping because it is most asymptomatic, and so it is always for the first line doctors who is seeing, always go for evaluation. What sir was saying, it's the right message that don't ignore it. As if on examination is found to be rubbery, it is and painless. Initially never it is a painless, it is a painful lesion or better than painless lesion. If swelling is painless, always be aware of that. Painful means there is inflammation and maybe some other sort of reaction. So it is a very, very important point of and always one patient I remember from Jamshedpur, sir, from male surgical ward. It was admitted to ward 2. There is a picture was very good. They have referred from us. He belongs to my Jamshedpur, my own colony. He came. He was having some X-ray and it was some mass-like structure. So it was CT was done. CT was saying there is something mass is there. Do the FNSC. Then chest unit here Dr. Malik tried to consult with B.R. Singh doctor. They have taken the patient. In B.R. Singh, they have gone there and at the time of doing it here, they said, it is very difficult. It is hazardous for doing the FNSC and the biopsy for. Then again, they returned back to here. Then we have sent him to Perambur for cardiac surgery unit. They have opened completely and finally it was found to be Hodgkin's. And young boy, hardly it was a 28-year boy, our employee, having mass, his problem was sometimes coughing dyspnea, that was he came. So sometimes even the Hodgkin's are in the central lesion, central part of the lesion, non-Hodgkin's side lesion. So if there is some suspicion of this lymph node with mass, always we have to be alert for because this incidence, what I am saying in coming last 20-30 years, Hodgkin's incidence is increasing. Even lymphoma is increasing. Lymphoma's incidence is increasing. So
we have a case presented with multiple para-aortic adenopathy, and we have done CT-guided FNSC that is inconclusive, that shows some necrotic material. And now we are outing for open biopsy. In the meantime, the patient has developed ascites and it looks like chylus, but we have excluded it. Only the necrotic material like pus we have drained. Unless we have done that biopsy, we cannot ascertain the diagnosis and still the patient is ATT. And because of anesthesia fitness, if patient is not going to be operated.
Burkitt, non-Burkitt, histologically, first line how you do? Yes, it is a non-Burkitt versus Burkitt.
Burkitt's lymphoma, I said, is a very highly aggressive tumor. So highly aggressive tumors are those tumors that are arising from the blastic cells. They are arising from the blast, immunoblast, centroblast. So the cells are very big with inconspicuous nucleus and opened up nuclear chromatin. And non-Burkitt's lymphomas are the other lymphomas where they are arising from either intermediate grade or low grade lymphomas arising from the mature lymphocytes. So morphologically they are totally different. Burkitt's was very highly aggressive lymphomas, big cells with this opened up chromatin and
Children are dead.
one thing just I will suggest from this case, you can say this is take home message. For every patient, I think peripheral smear is very